Hey, Greg.
Hey, Polly.
Oh, I thought I'd mix it up a little.
Hey, I like it. I like it. Brought the energy. Shoom, skyrocketed through the roof.
Because it's so the temperature in here is so refreshing.
It's only about 104 in here. But it is hot because we have a hot topic today.
We do.
Yes, we are talking perinatal substance use, which I have quite a bit of trouble saying. I always want to say prenatal, but I'm here, it's the same.
Yeah.
So it's
Yeah.
gonna be cool. But Margo Katz, she's the chief of the perinatal substance use program over at Rhode Island Department of Health. She'll be our guest today. She's going to tell us all about this.
Nice.
Yeah.
All right.
So without further ado, joining us today on Totally Preventable, we have Margo Katz, the chief of the perinatal substance use program at the Rhode Island Department of Health. Margo, how are you today?
I'm well. How are you?
Doing pretty good. Doing pretty
Great.
good. I had a
Great.
few little hiccups with the perinatal word. So now I'm doing good now that I got it
You
out.
gave yourself up. You could have just kept that quiet.
I
Margo
know.
and I wouldn't wrap it out.
See,
No.
my podcast in me by being I can't even think of the words.
Transparent.
There we go. Transparent. Wow.
Authentic, right?
So, Margo, to start things off in the way we normally do, can you just tell us a little bit about yourself and how you got to where you are today?
Oh, sure. So it was a complete accident. So I started out in the entertainment field. I got my master's in playwriting. I went to Los Angeles. I wrote screenplays. I worked in TV. And then after 9/11, I needed to come back home to the East Coast. And there was a lot of money flowing from the feds after 9/11. And I got a position at Memorial Hospital of Rhode Island, working as the assistant director of the Center for Biodefense and Emerging Pathogens. And it was through that job that I learned how to build relationships, basically, throughout the state with physicians and nurses and others. And when Memorial closed, I ended up at the Department of Health. So I really am completely unqualified for this position. I don't have an MPH, but I do seem to be able to build relationships and programs. So I guess maybe that's where my value lies.
That is awesome. Screenwriting, my all-time dream.
Really?
I that's what every time anyone asks, like, what do I want to be doing, or what was my hobby, and I was like, oh, I just want to be a screenwriter.
Oh,
Wow, I might pick your brain about that.
please. Absolutely. I'd
Perfect.
love to talk to you about that.
Sure.
That's a whole nother.
That is a whole
That's
nother.
another podcast.
Can you tell us how common perinatal exposure to substances like alcohol, cannabis, nicotine, stimulants, or opioids are here in Rhode Island, and how does it compare nationally?
Sure. So in Rhode Island, every year we see about 5% of the 10,000 births we have are babies who are exposed prenatally to substances. The substances that we're talking about, though, aren't necessarily tobacco, but they are alcohol, cannabis, opioids, and stimulants like cocaine and crack cocaine. So while a substance exposed newborn, while nicotine or tobacco would qualify to to um, to be part of prenatal substance exposure, we're not counting that necessarily. But it's those four that I mentioned that we have an interest in.
Yeah.
Yeah. Where do we stand with the other states? Well, Rhode Island has been, in terms of our overdose death rate, um, uh, since I arrived at the Department of Health, we have been in the top count of states throughout the nation. And I think in terms of neonatal abstinence syndrome, while we're seeing a downward trend, we're still in amongst the top states. Rhode Island does have a substance use problem. Our overdose death rate has declined lately, which is fantastic news. Um, but while our NAS rate, neonatal abstinence syndrome rate, is declining, prenatal substance use is not. So that's telling you that there are other substances of exposure that are occurring. Does that make sense?
Mhm.
Yes, yeah.
Yeah.
Now, what does the current landscape of neonatal abstinence syndrome look like in Rhode Island?
So, as I said, the NAS rate is declining. I think it's recently maybe 40, the rate is 44 out of 10,000 births. But we are still seeing prenatal substance use and the effects of it. And the fact of it actually is what we are following. The fact of substance use during pregnancy. Again, alcohol, cannabis, opioids, and stimulants.
Now, can I this might be a question that's either further down, but it just keeps popping in my head. When we were talking about the overdose numbers, child be born overdose in like the state of overdose, or
So that's a really interesting question. Nobody has ever asked me that. So so full disclosure, I'm not a clinician, but I can tell you that when a baby has been exposed to opioids in utero, when they are born, they wait 5 days to see if there are any signs of withdrawal, because just like an adult would experience withdrawal with the cessation of opioids, the baby after they're born is no longer getting the opioids that they were in utero. So it's a matter of looking for the signs and symptoms of neonatal abstinence syndrome, which would be things like poor feeding, diarrhea, excessive crying. There's a very high-pitched crying to these babies. These are all signs of withdrawal that you would see in a, but they're little babies. So it's really just a mirror. Withdrawal is withdrawal is withdrawal. But I've never heard about, I imagine if the mother overdosed while the baby was still in utero and the mother died, then unless they could save the baby would die. I think that's the answer to your question. A
Right.
big, I don't know.
That's fine. I
Now,
expect that answer.
now I'm going to be thinking about that. but,
Yeah.
Can you walk us through how Rhode Island's Circle of Care program works for infants exposed prenatally to substances?
Absolutely. Sure.
Up on prenatal in here.
No, prenatal is right. Prenatal is fine. It's just as good as perinatal. It's easier to say though. So our Rhode Island's plan of safe care is called Circle of Care. Plan of safe care is a federal mandate that says all children who experience prenatal substance exposure and their adult caregivers must be offered a sort of a care coordination plan after the baby's born and before hospital discharge. Rhode Island has approached this from the very beginning in a completely different way than other states, and it's something I'm actually quite proud of. The legislation that mandates plan of safe care falls under child welfare. But in Rhode Island, child welfare, DCYF, came to us, the Department of Health, and said, how can we do this so that plan of safe care doesn't come with the pejorativeness of child welfare? Because it really is, it's related to a public health issue, right? A crisis. So the two, Rhode Island Department of Health and DCYF, both agreed that the Department of Health should own plan of safe care. In doing so, it gives a protective flavor to plan of safe care and a public health flavor. And those are interchangeable, I think, public health and protection, right? So the other thing, so plan of safe care or circle of care, that's a new name and I have to get used to it. Circle of care takes place at the hospital generally, right before discharge. Families who have a substance-exposed newborn are offered a circle of care plan before they're discharged. And what that is a list of resources and referrals for both the baby and the adult caregiver. If the baby is going home with mom, then it's the biological mother. If the baby's going home with foster care, it's the foster family. We also try to offer mom, if the baby is going home with foster care, her own plan so that it can address some of the resources related to recovery and treatment and things like that, so that mom can, move forward with her own recovery and hopefully be reunited with baby. Plan of safe care is voluntary. And part of that is we want families to be part of building the plan, the circle of care plan. I keep saying plan of safe care. So they're offered a plan, a circle of care plan, and they can decline it, and there will be no repercussions, or they can accept it and then work down through all the resources that are offered. And then the plan is printed out and they go on their way. The other part of it is that some of their community providers, like the baby's doctor, like family visiting, and I'm trying to think of early intervention, they can also see the plan. They can only see the referrals on the plan, which is really what it's made up of. And that helps them reduce duplicative referrals, because you don't want mom to be given referrals to A, B, C, D. She goes home, she goes to family visiting, and they say, okay, I'm going to give you the same referrals. That makes absolutely no sense. It doesn't make sense for the resources, for the referrals, nor does it make sense for mom, who is already struggling with a little baby in the house, possibly her own recovery, and no sleep, and all the things that come with having a baby at home. So we're really hoping to make it meaningful, that it will reduce duplicate referrals, and it will help providers help mom. And also give mom some ownership of the supports and services that she is choosing, because it's not simply what she wants, what she needs. It's really should be about what she wants, right?
Yeah.
Agency.
Yeah.
Yeah.
Now, what are some of the biggest barriers that prevent pregnant and postpartum people from receiving like bias-free or
Oh.
equitable care?
I would say that fear and shame that comes from bias and discrimination. Women who use substances, and I'm talking generally about illicit substances, right? Cocaine, opioids, non-prescribed opioids, heroin, fentanyl, that they are deathly afraid of that baby being taken away from them. And so the instinct is to hide and to not seek prenatal care for fear of DCYF being called. And that in and of itself is creating a snowballing a bad situation, because prenatal care is part of having a healthy pregnancy. Not using substances is part of having a healthy pregnancy. And so by hiding, if you eventually end up at the hospital to deliver, you're going to be found out. And without any supports or services having taken place during your pregnancy, you're going to be in a really difficult situation. So my job here is to create interventions as early in pregnancy as possible to ensure that that women who use substances during pregnancy have access to things like perinatal peer services, family visiting, and all the things that go along with taking prenatal care, taking care of women during pregnancy. Rhode Island is a very resource-rich state. What comes with that is confusion and the inability to really understand, because everything starts with RI, right? What's out there for me? But if you have someone who can walk alongside you, like a peer recovery specialist, they can actually help you discern what are the things you need to do to ensure that you're going home with that baby.
It wasn't until Margo said that I started thinking of all the acronyms of all the resources that are helping.
Yeah, everything's
Like
right.
RI is
Yes.
RI, yeah.
All right, exactly. And it's all very clever,
Right,
Yeah.
but it's very confusing.
exactly.
Yeah. Yeah.
Mm.
Yeah.
Looking at Rhode Island's annual perinatal substance use conference,
Mm.
What recent best practices or innovations are being shared that you think could really shift the field?
That's a great question, especially because that's my conference.
Okay.
I feel like you've been on my website, actually. You're asking all the right questions. So I can tell you exactly. We have a number of interventions and programs and projects that we have developed here at the Department of Health and with our state partners for the past 7, 8 years or so. One of them is perinatal peer services. The importance of that is this is a workforce that has lived experience, pregnant and parenting, and using substances or being in recovery. And they're trained to be certified peer recovery specialists. Alongside, this is their job. And with that comes a set of standards and practices. They're professionals, but with that lived experience, they have actually proved to be the most important resource for pregnant women who are using substances because they have walked the walk and they can talk the talk. And Rhode Island's perinatal peer workforce was created by Parent Support Network, and we didn't really have that workforce before they did that. About 7 or 8, this all happened about 7 or 8 years ago. And right now, in the state, we have not that many perinatal peers, but the folks that we do have do tremendous work. And in fact, um, these are not at PSN, the peers that I'm going to mention, but if anybody wants a peer who has this experience and can help them in pregnancy or after the baby's born, they can call 401-895-6592. And that phone is will be answered 24/7, or if not, they'll be the message will be returned. You can text that number. That's part of our messaging campaign out of the Department of Health. Pregnant using We Can Help. They're a tremendous resource. So that workforce, rebuilding that workforce is a big priority in the state, especially for the Department of Health. The second thing is that DCYF has a substance use coordinator whose job is to intercept hotline calls that are related to prenatal substance exposure and to triage those calls and to refer appropriately to the perinatal peer services. This doesn't exist anywhere else in the United States, I can guarantee you. It really gives an opportunity for women who are pregnant, who have been reported for prenatal substance use, where there are no other children in the house. DCYF has a no baby, no case policy. So historically, they would get the call and they would sit back and wait until mom delivered. And then they would swoop in and there would be nothing set in place for mom. And more likely than not, the baby would be removed. What's happened since then is this preventative approach where, although not totally preventable, it's an opportunity to for mom, if she engages with the peer, to right the ship before the baby's born, get into recovery, treatment, um, parenting classes, housing opportunities, maybe go to Starbirth, which is the mother baby treatment program, Amos House, any of the resources we have here in Rhode Island. And the bottom line is we want mom and baby to go home together as long as it's safe. That's the second intervention. The third is that we are also funding street outreach teams here in Rhode Island to offer early pregnancy tests, referrals to prenatal care, referrals to perinatal peer services in the hope of, again, engaging perhaps one of the more vulnerable groups of women in the state who may be unhoused or have suboptimal housing, who are using to have some control over when they get pregnant by giving them the early pregnancy tests, and then making sure that they can connect to safe and welcoming prenatal care. The fourth one is coming up soon, which is Rhode Island has a street medicine program, which is another group that you should have on your show, actually. Becky Karb, out of Rhode Island Hospital. Street medicine goes to people in encampments, under bridges, living in their cars, people who aren't going to access health care in brick and mortar places who can't. And so they bring medicine to them. And it's very, very important. These are the most vulnerable people. So it's very, very important that that street medicine continue and that it's funded by various entities, including giving them the resources to focus on my population of interest, right? Pregnant women or women of childbearing age who can get pregnant, to ensure that they can get pregnant when they want to, and that when they do get pregnant, that they have a healthy pregnancy that is monitored and that their recovery is also tended to. So those are the four things that have come out of the work that we're doing, but that has been shown at the conference to the audience that attends.
Now, what trends are you seeing when it comes to pregnant individuals when they're using multiple substances?
You mean drug trends?
Yes.
So opioid, opioid use is down. Anecdotally, stimulant use is up, alcohol use is up, and that started during the pandemic. And honestly, we don't have very good data on prenatal alcohol use. I don't think there's good screening for that. It's not asked about a lot. There is no safe amount of alcohol during pregnancy at all. And I think that also it is fetal alcohol spectrum disorders are not well diagnosed in the state. So this is something that we have our eye on. Fentanyl is in the drug supply. So very often you will see unintentional polysubstance use because somebody is using one substance and there's fentanyl in it and suddenly, it's polysubstance. Cannabis use is huge. Actually, more than half of the substance exposed newborns in Rhode Island are exposed to cannabis. So, and this is a trend that other states are seeing as well. What we don't see a lot here, I was just talking to someone from Kentucky who asked to consult with us because of how great we are. We can do things in a different way because we're so small, and I don't know why we have the relationships. But anyway, she was saying they have a lot of methamphetamine use amongst pregnant women. I don't see that so much here. But to have an effective substance use program, you have to follow the drug supply, right?
Right.
Yeah.
So that's what we do. It used to be all opioids. That's all we focused on when I came to Rido. And then I thought, you know what? It's not the only substance in town. So we need to really focus on everything because, as you've seen with cannabis use, it has really superseded everything almost. Now, the effects of it aren't as acute as opioid use, right? Fentanyl, cocaine, crack cocaine. But there's so much we don't know about it. And I think the effects are going to be long-term down the road when the kids who are exposed to it in utero are experiencing developmental issues, learning issues, attention issues. The science is catching up, but it's not something that has been researched up until now.
You guys have a great dashboard on cannabis use and pregnant people use, or I forget how it's worded, but it's other things, cannabis and other things, but
Yeah,
the great
yeah.
thing about
Oh, the
pregnant-
Pori website?
Yes, yeah.
Oh, fantastic website. Absolutely. That's where I get all my data. Absolutely. Yeah.
Let's see. What emerging treatments, or behavioral interventions are showing the most promise in helping pregnant or postpartum people reduce or stop substance use?
So the gold standard, the evidence-based gold standard to treat pregnant women who are using opioids is medication-assisted treatment with methadone or buprenorphine. Period, stop, end of story. It is true that I'm going to say on the street, there are people who think that pregnant women should stop their treatment when they get pregnant because they're saying they're just substituting one drug for another. Addiction is a disease. It's not a moral failing. You have to, if you're going to have a culture that does not vilify people who use substances, particularly pregnant women, you have to believe that methadone is to opioid use disorder or buprenorphine what insulin is to diabetes. It's a medicine for a disease, full stop. That's what we believe in at the Department of Health, BHDDH, DCYF, EOHHS, everybody in Rhode Island who is doing this work believes this, as far as I know. But it's certainly a tenet that we hold close to our program.
Now, what kind of validated screening tools are available for clinicians during this care?
So there are quite a few, I believe. SBIRT, screening, brief intervention. I don't remember what it stands for. Anyway, SBIRT, the 4Ps, the DAST. These are all validated screening tools that providers can use to get a handle on what a pregnant woman, what their experience journey may be with substances. These are verbal screening tools. They're voluntary. I firmly believe that screening should be universal in Rhode Island, that providers should not, and I'm not alone. The ACOG, the American Academy of Obstetrics and Gynecology, also believes that there should be universal screening. But we know that providers are not screening universally because there is implicit bias. If you have me in front of you, master's degree, white, a decent zip code, you're probably not going to screen me because I don't look like I'm using substances. But if I maybe don't look particularly educated or don't sound educated, or I'm not white, or I'm of another ethnicity, or my zip code is another zip code where maybe there's some trouble happening, they might screen me, not simply for who I am, but what I look like and where they think I come from. That's bias. That's discrimination. I can assure you that's happening. Universal screening should be mandated. Everybody should be screened from Barrington to Central Falls.
It should be universal.
That's right.
Absolutely. It should be.
Universal
Right.
screening should be universal.
Universal is universal is universal.
Yes.
Right. Right.
Can you tell me how prescribing practices for opioids play into this conversation, and if there's any alternatives that exist for pregnant people who might be trying to do some pain management?
So it's inevitable that if you're pregnant and you have pain management needs, you may have to stay on opioids. I would say a conversation with your doctor is the first thing to do. There are, of course, over-the-counter options. There may be other pain medication, but we do see pregnant women who remain on opioids for pain because it's medically appropriate. And so we don't want to have women stop taking their medicine because there's a certain risk to the baby. The risk is manageable should the baby get NAS. It's really important that mom remains as healthy as possible.
Now, why is I'm tripping over my own words again. Why is the postpartum period such a high risk time for relapse? And what kinds of supports or systems could better protect both the parent and the child?
They call the postpartum period the fourth trimester. And if you've ever had a baby, I can guarantee you that your life is just not the same afterwards in any variety of measures. Um, One of those is that during the fourth trimester, or the perinatal period or the postpartum period, your body is readjusting to not having a baby inside of it. Hormones, mood swings, um, uh, time, time to manage your own recovery, sleep, anxiety, all of the external and internal stressors that occur in the fourth trimester. Add to that somebody who is struggling with addiction or trying to manage their own recovery and treatment. It's even if you don't have a substance use disorder, it can be a perilous time. Not having support, family support, friend support, having your baby taken away at the hospital, the trauma of that, this all feeds into why the postpartum period is so important to pay attention to in women with substance use disorders. Um, yeah.
I know after my first child, I can remember being super happy and excited and just crying, like just
Yeah.
crying for days about like just
Yeah.
being overwhelmed. And now I'm responsible for this tiny little human, and it was so overwhelming.
Yeah. It's absolutely overwhelming. And if life is overwhelming beforehand,
Yep.
Right.
imagine, right?
Mhm.
So it's really, really important to have supports in place to help, because we can't do it alone,
Mhm.
and we shouldn't have to do it alone. Um, there's no prize at the end for doing it alone. The opposite of addiction is actually community. And I think in no better time period is that true than in pregnancy and right after the baby's born. And it's so important to not be, there's the concept of the bad mother, right? The bad mother, it could be as simple as that the bad mother is working full time and has to put their baby in daycare, or the bad mother is using drugs, has a disease. Um, there's any number of stories about what a bad mother is. Women are really held to a different standard than other people. And I think when you are vulnerable and you're being perceived as a bad mother because you're pregnant and you're using, that the ramifications of that are great. And go back to living in the shadows.
When infants are exposed to opioids in the womb, how often do they develop withdrawal symptoms, and what determines whether these symptoms will be severe or mild?
Oh, what a great question. I wish I was a doctor. So does my mother. Um, I think the data says that 50% or higher could get NAS. So not all opioid exposed babies will develop neonatal abstinence syndrome. That's really important to know. If mom is in treatment, then she is under the care of a physician and a treatment team. And so it is unlikely, if she's otherwise healthy, that the baby will not have intensive complications. If mom is using fentanyl or other things out on the street and she's not under the care of a treatment provider, then it's, I believe, likely that the NAS symptoms could be more severe. And those babies sometimes we see them in the NICU because there are other complications as well.
What treatment options are considered to be safest and most effective for opioid?
For mom?
Yes.
Oh, so that's MAT, medication assisted treatment. That's the methadone and the buprenorphine again. And that's really critical to, those are opioid agonists. And again, as I said before, it's like insulin for diabetes. It's medicine for opioid use disorder.
So we've all heard outdated and harmful terms like crack baby.
Mm, mm.
Looking back, how did stigma and moral panic shape research and policy, and what
Yeah.
lessons should we carry forward?
Yeah. So the war on drugs is an example of the I'm not going to be able to say this right. This is like your perinatal thing. Politicization. I'm not saying that right. But it's basically taking a moral stance on addiction and using it against people, the criminalization of substance use. And back in the day, and some would even say today, um, there part of this is relative to racism. And crack moms and crack babies, the the people that we would see in the news were Black women and their children, while cocaine in the white community was sort of, you'd see it in screenplays and it was related to wealth, right? And partying. So very, very different drugs and different messages, and people were treated differently for the drugs they use, and they still are, frankly, right? So I think that when the opioid crisis reared its head, it was a crisis that was affecting white middle class people. And suddenly we were looking at addiction as a disease as opposed to addiction as criminalizing addiction. So even the shift is related to racism. It was a beneficial shift because things are different now for my population. You know what I mean? But it's still related to racism, and I think that has to be acknowledged. And we're again seeing it being politicized, and perhaps that never left.
Unfortunately.
Yeah.
Yeah. How are hospitals and pediatric providers changing the way they manage neonatal abstinence syndrome, particularly when it comes to non-pharmacologic strategies versus like default NICU admission?
Well, when I came to the state, Women and Infants had just created a new service line. Women Infants Hospital had just created a new service line called the Family Care Unit, which was expressly for babies who were opioid exposed. And this was a small, quiet, dark, calm unit right off the mother-baby unit that took care of these families because the babies needed something different. They needed maybe prolonged care, and they needed clinicians who had an expertise in how to take care of babies with NAS. And so this reduced the amount of NICU admissions because babies could be taken care of in the family care unit. Some of them get medication. Some of them don't need medication, but they use something called a Finnegan score, which scores the withdrawal symptoms that the baby is experiencing as witnessed by the clinicians. And then the care plan is created accordingly based on what they're witnessing the baby go through. They have wonderful neonatologists there at Women and Infants who take care of these families. There's the option for mom and or dad to room in if the baby has a prolonged stay, because mom, of course, will be discharged before the baby if baby is staying longer to be medicated. So there's the rooming in option if it's appropriate. There are social workers. There's a family navigator who's exceptional. Her name is Erica Oliveira. The peer recovery specialists are well known to that team, as is Stevens at DCYF, the substance use coordinator. And they're often called in to help with families and babies and moms. So it's really it's an excellent opportunity. They also do prenatal consults. If mom will go in, she can get an idea of what may happen. They'll do a 5-day watch for NAS, that baby may have to stay longer, that there's a rooming in option if it's appropriate, et cetera, et cetera. So Women and Infants does a great job. Newport Hospital, I believe, also keeps their NAS babies. They don't ship them to Women and Infants, but the other hospitals will transfer babies to Women and Infants if they have withdrawal symptoms that need to be treated.
Learned a lot.
It's a whole bunch.
Yeah.
It's a lot, isn't it?
It's a lot. Yes. I loved that hearing about the street medical team or whatever. Because as you were speaking, I was like, how on earth, if people are already traumatized by stigma and trying to hide out, how on earth do you reach these people? So love all those interventions.
Yeah, you got to go to them.
Yeah, absolutely.
Can't wait for them to come to you. Yeah.
Especially like the postpartum emphasis. I am not afraid to admit that I wasn't not until I had my first child, but until our first child, I really didn't hear much or know much about postpartum. But now that I've gone through it and I've seen other family members and friends who are going through it, and like now that it's recognized, I really love that there's an emphasis put on there, because I could see how that time frame, that fourth trimester, I can see how that could be a very big opening for either experimentation, continuance. So for all as you're doing. I will be remiss if I don't say, for anyone listening who would like to get in contact or to learn more, what would be the best way to get the information?
Oh, you're asking me to remember my URL, which I certainly can't remember. I can't even remember my own name. So I would say go to the Rhode Island Department of Health website. That is, if I can remember that, health.ri.gov. In the search bar, type in perinatal substance use, and there should be a page about the work that we're doing. You can also go to Prevent Overdose Rhode Island, another website, PORI, which has great data, great resources, including our messaging campaign, Pregnant Using We Can Help. The other, if I may, the other resource that I didn't get to mention was family visiting. Family visiting is a free, confidential, voluntary program that is statewide, that brings nurses and social workers and community workers into your home to help you navigate having a baby in the house. And that also can be searched for at the Department of Health website. We do train family visitors on substance-exposed newborns and perinatal substance use. And so they are well versed in referring to the peers, and the peers are well versed in referring to family visiting. So we really try to create a continuum of care to support this population.
To that one woman who's now using and pregnant, what would be the one nugget that you would want them to take away from this podcast?
You're not a bad person. You have an illness, and you don't have to walk through it alone. I would encourage anyone who is struggling with a substance use condition during pregnancy, to call a peer recovery specialist, 895-6592, to text. That is non-judgmental, boots on the ground help. They will be by your side from the moment you call to perhaps years after you deliver. And they will help you put, if you're ready, they will help you put resources in place to help you and your family. Help is out there. It's just sometimes it's hard to ask for help.
Thank you so much, Margo, for all these great resources and
My
information.
pleasure. Thank you for the platform. I appreciate it.
Pleasure. Have a great rest of your day.
Thank you. You too. Do I leave now? Take care. Okay, bye-bye.